Hello everyone, my name is Guo Ting, come from Reproductive Hospital affiliated to Shandong University. Today, I will give one presentation about reproductive aging. The rate of attrition of a woman's lifetime stock of oocytes is inexorable. As the clock shows, the female reproductive lifetime can be defined at the time between puberty and menopause. The reproductive aging begins after women reach their mid-30s. The timing of menopause ranges from 40 to 60 years of age. The average age of menopause onset in Chinese females is 48. As the age increased, the monthly birth rate dropped sharply. Reproductive aging not only demonstrates with infertility, but also present with increased rate of miscarriage and chromosome abnormalities in offspring. In the general population, the risk of miscarriage in a woman at 35 to 39 years of age is 24%, and doubles to 51% at 40 to 44 years of age, if the woman conceives with her own rather than donor eggs. Increased maternal age also associates with a lot of obstetric complications, including gestational diabetes, placenta previa, placenta abruption, hypertension, and cesarean section. Alongside with the social changes over the past 4 decades, large numbers of women attempt to conceive until their mid-30s or older. This figure shows the global data. The number of first birth per 1,000 women above 35 years of age increased by 23% between 2000 and 2014. In our center, the average age of females receiving IVF treatment increased 2 years in the past 6 years. The percentage of patients above 35 years has increased by 10%, while the percentage of women over 40 years increased double. However, along with aging, the number of derived oocytes is reducing. The clinical pregnancy rate and the live birth rate is reducing, while the miscarriage rate is increasing. Therefore, more and more women with advanced age are facing reproductive problems, and reproductive aging has become a social problem that should be paid more attention. Then, how can we evaluate the degree of reproductive aging? The ovarian aging is characterized by declining oocyte quality and quantity. Ovarian reserve has been used as a term to describe the quantity of oocytes remaining within the ovaries of a woman at a certain time point. And the IVF oocyte yield is thought to be the endpoint of ovarian reserve testing. The clinical biochemical predictor of ovarian reserve include FSH, AMH, and inhibin B. FSH is a gonadotropin secreted by pituitary and stimulates the maturation of primordial follicles. As the size of the oocyte pool diminishes, higher level of FSH is needed to promote follicle development. Hence, high concentration of FSH reflect low ovarian reserve. But because FSH is positively released, the curicity is insufficient. Inhibin B is produced by small androgen follicles in response to FSH stimulation, while AMH is mainly derived from pre-androgen follicles and is non-FSH dependent. Another index is androgen follicle count, which physiologically decline along with aging and directly reflect the IVF oocyte yield. Well, there are the drawbacks, that the test is operator dependent and requiring ultrasound facility. This is the comparison among FSH, AMH, and AFC. Each of them has advantages and disadvantages. To evaluate the ovarian reserve, we should put them together. Well, considering the reliable and high sensitivity, AMH has gained rapid acceptance in IVF practice and looks likely to replace FSH as the preferred biochemical predictor of ovarian response. All the above tests are reflective of the number of follicles remaining in the ovaries, rather than being measures of quality. Then, what is the predictors of oocyte quality? The fundamental process associated with oocyte quality is spindle formation, chromosome segregation, and mitochondrial function. But it is difficult to evaluate non-invasively. Clinical measures of oocyte quality we usually used are age, EFC, and IVF outcome. For young women with diminished EFC or known causes of early ovary failure, such as chromosome abnormalities, gene mutations, autoimmune defects, or permanent ovary damage, childbearing at a younger age might avoid the later resort to IVF and possible lifelong infertility. However, the markers of early ovary failure are still need longitudinal investigation. The strategies to ameliorate the impact of ovary aging on fertility include that pre-implantation genetic testing, oocyte-plasmic transfer techniques, oocyte donation, and fertility preservation. To improve the IVF outcome, pre-implantation genetic testing is recommended. This technique will screen embryo genome, choose an embryo without significant chromosome abnormalities, then transfer them into the uterus. Some studies found PGT could significantly improve the clinical pregnancy rate and live birth rate for the women at advanced age. Moreover, it is cost-effective, shortens treatment time, and reduces the risk of failed embryo transfer and clinical miscarriage. Therefore, PGT has been widely used for the older patients receiving ART treatment. Recently, new techniques such as polar body analysis has been tried. Notably, one RCT published on the New England Journal of Medicine, which was performed by our center, showed that for the women below 37 years old with 3 or more good quality blastocysts, the cumulative live birth rate from conventional IVF was comparable to PGT. That means PGT really should be recommended to the patients above 38 years old. Cytoplasm transfer, also known as nuclear transfer, is used to transfer the better mitochondria from donor eggs to the recipient oocytes. It will improve the chances of fertilization and implantation. But its safety and ethics are needed to be addressed. Now, it is only applied to the patients with mitochondrial disease in several countries. In the future, with the development of technology such as spindle transfer from sex to polar body, it might be used to improve the quality of oocytes at advanced age. For women who have no chance to retrieve their own oocytes, using oocytes from a younger, fertile donor will be the last approach. However, commercial oocyte donation is illegal, and the number of available oocyte donors is small. Although some basic researchers have generated the oocytes from stem cells, its clinical application still needs a long way to go. For the young women who have no childbearing plan in the short term or the cancer patients who will suffer cytotoxic treatment, the issue of fertility preservation has assumed greater importance. The strategy of fertility preservation include embryo freezing, oocyte cryopreservation, ovarian tissue cryopreservation, and autotransplantation. To date, embryo freezing is the only established method successfully and widely used for females with cancers. The live birth rate per frozen embryo transfer is 27% to 50%. Because IVF treatment requires oocytes retrieved from the females and the sperm from a male partner, this method is not suitable for prepubertal and adolescent girls. due to conventional ovary stimulation result in enhanced serum estrogen levels and the risk of developing ovarian hyperstimulation syndrome. Ovarian stimulation may not be suitable for women with estrogen-sensitive cancers or highly aggressive malignancies. Oocyte cryopreservation may be an alternative to embryo freezing to avoid the need of sperm. Recently, oocyte vitrification is preferred because of relatively less cryo injury and better outcome. However, the live birth rate per frozen oocyte is 2 to 6%. That is much lower than frozen embryo. So, if the two options are available, embryo freezing is preferred. Another strategy, ovarian tissue cryopreservation and autotransplantation, is a promising option in fertility preservation. To date, nearly 20 births have been reported. However, up to 70% of follicles will atresia post-transplantation, and this treatment has a risk of reintroducing malignant cells. So, the safety and feasibility of the strategy still need more evidence. Another strategies include in vitro culture of ovary tissue or follicles and in vitro maturation of oocytes. These methods are trying to improve the usage rate of premature follicles, but they are still considered experimental, not performed clinically. Here is the take-home message. First, reproductive aging cannot be stopped. The optimal age for childbearing is between 20 and 35 years. AMH and antral follicle count are the most sensitive predictor of ovary reserve. Although PTT might improve pregnancy outcome of women with advanced age, young females with a low ovary reserve should seize opportunities to have their own babies. We have to remember that fertility preservation cannot guarantee live birth. To remind young couples of reproductive aging is the responsibility of medical, educational, and social specialists. That's all. Thank you for your attention.